Hi everyone, myself Dr. Tarun Parmar. Today's topic is TAPVC, that is total anomalous pulmonary venous connection. So total anomalous pulmonary venous connection is a cyanotic congenital defect in which all four pulmonary veins fails to make the normal connection with the left atrium. This results in the drainage of all pulmonary venous return into the systemic venous circulation. So mixing of the deoxygenated blood in oxygenated blood in the right atrium. So this is the admixture physiology, and I want to make it clear that TAPVC and TAPVD is different. So TAPVD, total anomalous pulmonary venous drainage, in that the connection of the pulmonary veins is to the morphological left atrium, but it drains to the right atrium and RV. So TAPVD conditions are common atrium or septum primum malposition. So we are dealing here with the TAPVC, where the connection of the pulmonary veins is not to the LA. So incidence of the TAPVC ranges from 0.6 to 1.2 per 10,000 live births, and among newborns with CHD, the incidence of TAPVC ranges between 0.7 and 1.5%. Coming to the embryology part, so in the early stages of the primordial lung, birds are enmeshed by the vascular plexus of the foregut, the splanchnic plexus. So by the end of the first month, the common pulmonary vein establishes a connection between the pulmonary venous plexus and the sinoatrial portion of the heart. This common pulmonary vein that originates from the posterior aspect of the left atrium and just adjacent to the septum primum. And then this connection between the pulmonary venous plexus and the splanchnic venous plexus involutes, and the common pulmonary vein then incorporates or absorbs into the left atrium. So any modification in this process will lead to the abnormal development of the pulmonary veins. And if the connection between the common cardinal vein persists, then it will lead to the supracardiac TAPVC, and if the connection with the umbilicovitelline system remains, then it will lead to infracardiac TAPVC. And the important aspect in this is the common pulmonary vein that absorbs into the left atrium, and it will lead to formation of the two left side of pulmonary veins and two right side of pulmonary veins, and it forms a part of the LA. So in the TAPVC, this common pulmonary vein part is not form the LA, and LA is inherently small in this case. So embryology basis of the partial and total anomalous pulmonary venous connection. So TAPVC results when the failure to establish normal connection between the one or more pulmonary veins with the common pulmonary vein. And TAPVC is connection result from the failure of establishing normal connection between the pulmonary venous plexus and the common pulmonary vein. So what is the classification of the TAPVC? So most important classification is by Darling in 1957. These are the supracardiac TAPVC in 45% of the cases. Then cardiac TAPVC, most commonly the coronary sinus type, 25%. And then infracardiac TAPVC, that is 21%. And 10% cases, there is a mixed TAPVC when there is connection at different levels. So here are the most common connections. Most commonly, it connects to the left innominate vein, and then coronary sinus, RA, right SVC, portal system, or multiple sites. So come to the supracardiac TAPVC. So here what happens, all four pulmonary veins forms a confluence, horizontal confluence, then drain into the left ascending vertical vein to the left innominate vein to RSVC to RA. So there is a complete mixing in the RA, and there is obligatory shunt at the ASD level. So that is a part of the TAPVC, that is not the different defect. And it is obligatory because the survival is dependent on this defect. It shunts right to left, and there is a long circuit of the pulmonary venous connection. This is the heart and lung specimen that's showing this is the right pulmonary vein, this is the left pulmonary vein that forming the common horizontal chamber, and it goes to the left ascending vertical vein to innominate vein to RSVC to RA. Here you can see this common vertical vein, ascending vertical vein, is most commonly sandwiched between the left pulmonary artery anteriorly and the left mainstem bronchus posteriorly. That is also known as the bronchopulmonary vise or hemodynamic vise. So this is the most common site for the obstruction of the ascending vertical vein or TAPVC. You can clearly see there is a poststenotic dilatation of the left vertical vein. Next is the cardiac TAPVC. Here all four pulmonary veins forming a confluence and draining into the coronary sinus that is dilated and then drains to the right atrium. So here is the echocardiographic representation of the cardiac TAPVC. Here you can see this is the dilated coronary sinus, and this is small left atrium. That is because of a left atrium is underfilled, and also the common pulmonary vein that forms a part of the left atrium that is absent. So that is inherently smaller in size. This is the dilated coronary sinus, and this is the right atrium. You can see this red flow from the dilated coronary sinus to RA, and there is obligatory AST or PFO, right to left shunting. Third is the infracardiac TAPVC. In this all four pulmonary vein forming a confluence and then draining into descending vertical vein. This descending vertical vein is it lies anterior to the esophagus. It passes through the diaphragm from the esophageal hiatus in the diaphragm, and then it drains to the portal vein, or maybe sometimes hepatic vein, or directly in the IVC. But invariably it is going through the hepatic sinusoid, so almost always that is obstructed. There are other sites of obstruction, like confluence may be small. There is obstruction in the vertical vein at the diaphragm where it enters into the diaphragm, and at the entry point in the portal vein, or it may be almost always obstructed in hepatic sinusoid level. This is the pictorial representation of the infracardiac TAPVC that is directly draining into the IVC. And mixed TAPVC, there can be any combination like 2+2 pattern or 3+1 pattern. In 2+2, each lung unite, this vein from each lung unite and then drain into different sites, and 3+1, that is most common. 3 pulmonary vein drains into the common confluence at a certain cardiac level, and another vein that is draining separately. So these are the 2+2 pattern, pictorial presentation of the 2+2 pattern of the mixed TAPVC. This is the most common in that mixed variety, 3+1 pattern. And these are the bizarre. So any combination can be possible. So we have seen in the embryological aspect also, when the connection between the common cardinal vein persists, that will lead to the supracardiac TAPVC, and the connection with the umbilicovitelline system persists, then it will lead to the infracardiac TAPVC. So now most common thing is anatomic sites of obstruction. So like in every TAPVC, IAS is very important. The longevity of TAPVC depends on the size of the AST. So the patient who survives beyond the infanthood and in the early childhood or adulthood, they have non-restrictive ASTs. So restriction in the AST, that is directly related to increase in the mortality. So then another obstruction occurs at the intrinsic narrowing the wall of the anomalous venous channel, or extrinsic narrowing by the structure. So these are the pictorial diagram showing that we have shown in the heart-lung specimen. This is the mainstem bronchus, and this is pulmonary artery anteriorly, and this common ascending vertical vein that is compressed between these two structures. Infradiaphragmatic or infracardiac TAPVC are almost always obstructive. So these are the common sites of obstruction. Supracardiac 25 to 50% cases are obstructed. Cardiac, most commonly they are non-obstructive, but still 17 to 20% are obstructed. Infracardiac almost always obstructed. In supracardiac TAPVC, most common site is hemodynamic device that we have seen. Then narrow ascending vertical vein, then vertical vein LIV junction, then RSVC RA junction, or azygous vein drainage. In cardiac TAPVC, common this confluence to CS junction or a junction with the RA. Or infracardiac TAPVC, there are different sites of anatomic, or it passes through the esophagus, or it is intrasinusoidal, hepatic sinusoidal level, it is obstructed. And always restricted AST or PFO is a site of obstruction. So what is the hemodynamics and physiology of the TAPVC? All venous blood that enters into the returns through the RA. So communication between the right and left side of the heart is essential for survival. That is in the form of most commonly in the AST or PFO. The physiology feature depends on the this distribution of the mixed venous blood between the pulmonary and systemic circulation. The state of the interarterial septum is very important, as we have seen. So this is the supracardiac, non-obstructive type of TAPVC. In the pulmonary, blood flow is very much high. That is almost 3 to 5 times the systemic blood flow. So QP/QS ratio is 3:1, and saturation is like 85, in the range of 85 to 90 to 93%. And in the obstructive case, there is QP/QS ratio is 0.7 to 1%, and saturation is very low. There is RVH and RV dysfunction. So TAP is without pulmonary venous obstruction. So RV receives most of the blood from the RA, then ejects large volume of blood to the PA. There is a mild cyanosis, and state of the interarterial communication very important. So RV is dilated and PA is dilated. Initially there is low PVR, so there is increased QP, and there is compliant RV. So as the time progresses, there is increase in the pulmonary vascularization, and then less compliant RV. So in that case, the pulmonary blood flow reduces and cyanosis increases in the later stage of this TAPVC without pulmonary venous obstruction. But TAPVC with pulmonary venous obstruction, pulmonary vein exhibit intimal proliferation, thick wall reduction in the size. So low LV volumes, low systemic output due to inadequate filling. There is pulmonary congestion, pulmonary hypertension, there is pulmonary edema, and there may be the decreased pulmonary blood flow and then increased cyanosis. There is pulmonary hypertension, dilatation of pulmonary trunk compresses the vertical venous further, and there is vicious cycle. So there is reflex pulmonary arteriolar constriction that will lead to the pulmonary hypertension, RA-RV dilated and RVH, and then ultimately RV fails. So in the natural history, 75 to 90% of the symptomatic infants are unable to reach complete first year and succumb in the 3 to 6 months. So 50% of the patients who survive to age 3 months are alive at 1 year. Survival depends on the types of TAPVC, like supracardiac, infracardiac or what, then low PVR and the non-restrictive AST. So obstructive TAPVC has a grim outcome, and some patient may reach to 50 decades of the life. These are the most commonly the non-obstructive TAPVC. These are just like the large OS, present as a large OS AST with mild cyanosis. So clinical features of the TAPVC, that is also divided into two parts, without obstruction and with obstruction. So non-obstructive TAPVC mostly asymptomatic at birth. Tachypnea and feeding difficulty usually occur first few weeks of life, followed by respiratory infection and failure to thrive. Mild cyanosis, gradually they develop right heart failure and PAH, cardiac failure in most patients prior to the 6 months of age. And with obstruction, tachypnea, tachycardia, cyanosis, etc., these patients are very sick during the initial period of time. If left untreated, they succumb to death due to pulmonary edema and RV failure in the first few weeks of life. There is dyspnea and cyanosis, and there is usually not within the first 12 hours of birth, that is differentiated from the respiratory disorder. So there is hyaline membrane disorder that mimics this obstructive TAPVC. So, but this hyaline membrane disorder or respiratory cause of the this cyanosis, that is very immediate, and there is intercostal indrawing and other signs that is different in the obstructive TAPVC. So these are usually mildly symptomatic during the first few hours of life and then become the very symptomatic. So these are the clinical features. So unobstructed TAPVC, RV, heave and cardiomegaly are there, hyperactive precordium and RV apex, and there is multiple cardiac sounds, loud S1 due to this tricuspid valve closure, then ejects and click, wide and fixed split S2 just like in AST, there is S3 gallop, or plus or minus S4 due to atrial systolic murmur. And then this soft blowing is just a systolic murmur due to increased pulmonary blood flow. There is systolic murmur of the tricuspid regurgitation. There is mid-diastolic murmur due to increased blood flow through the tricuspid valve, and there is venous hum because of the TAPVC to the LIV, that is ascending vertical vein. This is different from the innocent venous hum in that the head posture will not affect the sound of the hum. There is tachypnea, hepatomegaly, peripheral edema, and variable degree of cyanosis. In obstructed TAPVC, no significant RV, heave and cardiomegaly. P2 is loud, murmur is absent or TR murmur is there. There is marked cyanosis, increased respiratory effort with no significant retraction. That is different from the respiratory cause of the illness. Then there is hypotension, weak pulse and poor perfusion. That is because of the low cardiac output, and there is rales at the lung basis, and there is hepatomegaly and peripheral edema. These patients are very sick. Chest X-ray. This is the typical figure of 8 appearance. This happened in the post-infancy, and this dilated shadow in the mediastinum, it is due to left side, it is due to left ascending vertical vein. This is due to innominate vein, and the right side is dilated RSVC. And this is in the neonatal period, and this shows the ground glass appearance. This is X-ray of the infracardiac TAPVC obstructed. ECG mostly showing right atrial dilatation, RVH, and there is incomplete RVBP pattern due to RV volume overload, and there is right atrial enlargement. Echocardiography is the most important investigation in the TAPVC. So apart from all the segmental analysis and saying all the structures, we particularly see the size and course of the individual pulmonary veins, then connection of the all four pulmonary veins, then size and location of the confluence, then course of the pulmonary channel and level of the obstruction, and then other interarterial communication, AST size or any associated defects. This echo shows, this is the still image of the TAPVC. Here you can see this is a common feature in all TAPVC. RA and RV is dilated, and there is a bowing of the interarterial septum to the LA. There is a obligatory PFO bar AST, and there is TR in this case. This is suprasternal short axis. The most common important views are suprasternal short axis view and the crab view or and parasternal short axis view. Here you can see the all four pulmonary vein is draining into common confluence. This is the left upper pulmonary, this is left lower, this is right upper and right lower. This is the Doppler interrogation of those. The suprasternal crab view. This is the still image of the TAPVC, where all four pulmonary forming a confluence. There is right lower, right upper, left lower, and left upper pulmonary. You can clearly see this red chamber. This is a good in size. This all four individual pulmonary veins are good size. This left upper pulmonary vein is the last pulmonary vein that almost enters into the ascending vertical vein. This is the classic figure of 8 in this 4 pulmonary vein draining into the confluence, then left ascending vertical vein to innominate vein to RSVC. Here you can see the same pattern for pulmonary vein draining into the confluence to innominate vein, ascending vertical vein to innominate vein to RSVC. So here echocardiographic representation of the site of the obstruction. Here we can see at the level of the bronchopulmonary vise or hemodynamic vise, as we have described, because of this ascending vertical vein is compressed between the LPA anteriorly and left mainstem bronchus posterior. So there is mosaic or this turbulence pattern. Here you can see turbulence pattern or mosaic pattern, and there is a gradient. Here is another site of obstruction, that is junction of the vertical vein to left innominate vein. This is at the level of the SVCRA junction obstruction. Here you can see the mosaic pattern at the level of the PFO. So see, in all TAPVC we have to delineate IES perfectly. We have to see the size of the PFO bar AST. So that is very important. This is the obstruction at the level of the PFO. Here are echocardiographic image of the cardiac TAPVC. You can clearly see there is a dilated coronary sinus that draining into the right atrium. RA and RV is dilated here. So here you can see the right and left pulmonary vein forming a confluence draining into the dilated coronary sinus to RA. There is AST, right to left shunting. This is Wells tail appearance. Here is the subcostal sagittal view, dilated coronary sinus draining into the RA, and there is a PFO that is shunting right to left, that gives the blue color. Here correlation with the Wells tail. This is a Wells tail, right and left pulmonary vein draining into the confluence and to the CS to the RA, and there is AST shunting right to left. Atria is very small. This is image of the infracardiac TAPVC. You can see when you see the subcostal sagittal view, this is the aorta and this is the another channel, that is TAPVC, infracardiac TAPVC. This is show the pulsatile interrogation, and this will give the continuous waveform beta. So cardiac catheterization is most commonly not indicated in nowadays because 2D echocardiography is enough for this thing. So whenever you do, you see the anatomic arrangement of the connection of the systemic veins and then obstruction is there or not. Most commonly it is used to define the pulmonary vascular resistance in the older patient for before surgery has been done. This is the typical angiographic image. You can see the catheter is in the PA And in the Leo phase, you can clearly see there is supracardiac TABVC draining into the RA. So this is another still images showing the site of obstruction. This is pulmonary vein confluence, and then this is obstruction at left ascending vertical vein. And this is the infracardiac TABVC showing tree in winter appearance. Role of CT and MRA. So if there is any doubt in the diagnosis with the echocardiography, you can always go for the CT imaging. That provides the excellent imaging of the pulmonary venous channel and any other extra cardiac anomalies. MR angiography is also when there is a doubt, you can always go for the MR angiography. It gives the very nice delineation of the pulmonary veins and all the structures. Indication and timing of surgery. All patients require surgical repair. Obstructed TABVC require emergency surgery. Unobstructed TABVC require early surgery during first few weeks of life. And if the patient present late, then you do cardiac cath and check for the PVR and then go for the surgery. So in management part, the surgery is the direct indication for this condition. So obstructed TABVC, as we have seen, the patient requires urgent or emergency surgery. And if the patient is very sick, respiratory support can be provided, assisted ventilation can be given, oxygen can be administered. And if the patient is in shock, inotropic agents such as dobutamine, dopamine can be recommended. And the role of PGE or prostaglandin is in non-obstructed TABVC, there is no such role. It may worsen sometimes, but in some cases of obstructed infracardiac TABVC, it can open up the ductus venosus, and that can be helpful during the initial period. So in the conclusion, obstructed TABVC requires emergency repair, emergency surgery. Echocardiography is the best diagnostic modality of the choice. If there is a doubt, then you can go for the CT or MRI, and then maybe cardiac cath if the patient is presenting very late and you have a doubt of the PV, pulmonary vascular disease. And surgical correction is the definitive treatment. Thanks.